Immune-related adverse events can develop after a patient is treated with immune checkpoint inhibitors. The most common side effects will affect the skin, and these side effects can also affect the mouth. In some cases, the mouth may be affected without there being any cutaneous involvement at all. Of course, there are many other potential manifestations of these IRAEs that can affect nearly any body organ. And these other features may or may not present in the context of oral IRAEs. Also, the timing can be highly variable. Patient may present with one specific IRAE, for example, colitis, and may develop another IRAE, such as mucosal inflammation or salivary gland involvement at a much later time. So the diagnosis is important, not always the easiest diagnosis to make, but in most cases, these are conditions that come on fairly abruptly. As far as the oral potential manifestations, we have several different rash-like features that can affect the oral mucosa, and the condition may also affect the salivary glands. As most of these toxicities more or less reflect known or otherwise established diagnoses for immune-mediated and or autoimmune conditions, the features that we see in the oral cavity can have features of many other conditions, actually including chronic graft-versus-host disease, in the sense that probably the most common mucosal feature is lichen planus changes, lichen planus-like changes, we like to say, because they're not always so classic for the typical diagnosis of lichen planus. This will present with oftentimes white reticular lacy changes, erythema or areas of mucosal erosion, as well as frank ulceration. Ulcerations typically having a very distinct appearance with a yellow or yellow-white pseudomembrane, and oftentimes the most painful of lesions. They can really affect anywhere inside the mouth. And these features are not always so distinct just for this diagnosis. We sort of think of there as being overlapping presentations, but we can categorize them a bit distinctly. So we have the lichen planus-like changes. We can see patients presenting with a much more non-specific type of inflammation that presents like an erythema multiforme, or in its most severe cases, more of like a Stevens-Johnson-like syndrome. Oftentimes with extensive lip involvement, lip ulceration and crusting, and very non-specific ulceration throughout the oral cavity. Less frequently, but has been reported, and we've seen examples, has been cases of bullous pemphigoid and or mucous membrane pemphigoid, typically bullous pemphigoid with oral involvement of the bullous pemphigoid. When the salivary glands are involved, patients will tend to present with a Sjogren's syndrome-like condition, in the sense that it's an autoimmune or immune-mediated sort of attack to the salivary glands, causing the mouth to become very dry. Tends to be a very abrupt onset. Patients will have less saliva, find it difficult to eat, drink, swallow, and may be at risk for developing not only cavities in the mouth, but other complications with the teeth, just because of the change in saliva composition and the lack of saliva. These patients may or may not require biopsy for diagnosis. In most cases, we diagnose clinically, and we diagnose based on the clinical context of even if a patient does not have other IRAEs. As far as management is concerned, we can manage the mucosal inflammation in some cases very effectively with topical corticosteroids and topical tacrolimus. Some patients may require dose modifications or dose reductions or break-in therapy. Some patients may require systemic therapy with steroids or steroid-sparing agents. But whenever we can, we try to manage these patients with local measures. Again, topical immunomodulatory agents, and in patients with salivary gland disease, we can treat with a number of over-the-counter dry mouth products. We can ensure good hydration and good stimulation of saliva using sugar-free gum, sugar-free candy, and other agents like this. And then we, of course, have prescription silagogue agents, which can also be very effective in these patients. As noted, the management of these complications, whether the mucosal disease or the salivary gland disease, ultimately, since they very much are similar to manifestations that we see with chronic graft-versus-host disease, are not so different.